I am truly honored to be here with such distinguished guests, with people that I've known probably for several decades and many whom I've just met. This is a wonderful audience. We are called to wake up and do all we can to create a health system where all people have access to resources, where all people have access to the dignity and respect that they deserve. My work as a psychiatrist at Mass General Hospital started as a clinician, evolved into doing clinical research and teaching. And the path has grown, and I feel fortunate to be in the company of all of you whose paths have brought you here today, because I think we all have a calling and we all have to be change agents, because the time is now to make change that is desperately needed in healthcare. I'm just disclosing and proud to say that because of the research that we've done as a team at Mass General, our empathy training that we developed became in such high demand that we needed to find a way to scale it up, and we created an online platform and also training opportunities to train trainers to bring healthcare transformation into organizations and change them from the top down and the bottom up. I love this quote: "The highest moral achievement is the care of all beings, human and non-human." Now, let me just ask you to think for a moment, who do you think said this? Was it the Dalai Lama? Was it Mother Teresa? Was it one of the scholars or in scriptures, the Holy Scriptures that are from many traditions? You might be surprised that it was Charles Darwin. Charles Darwin made the observation that it is not the strongest of species that survives, nor the most intelligent, but the one most responsive to change. I think we all know that the direction that healthcare has gone into in some ways is magnificent, and in other ways has left human beings behind. And we are the change agents that are going to create the change that makes us adapt to a system that we can be proud of, and one that we participate in as leaders and also as people who bring the joy, the practice, and the true meaning of delivering health care to those in need. So you may ask, is there really a compassion crisis? Well, let me just share a few headlines with you. When the doctor is in, but you wish he wasn't. Is there hardening of the heart in medical school? Medical school burnout and the challenge to patient care. For some doctors, empathy is in short supply. And the power of the bedside manner. This one says that a doctor's bedside manner may be the most innovative and the hardest to find. The fact that we're talking about the bedside manner as an innovation startles me, but that is where we are. We've got to get back to what matters between doctors, patients, nurses, patients, and between the teams of people who take care of others. So how do the American population rate the US health system? Research done by Dr. Lown and her team showed that 50% of patients and physicians said that the system was not compassionate. 75% of providers said that providers were compassionate, but 50% of patients said providers were compassionate. So we have a little disconnect between perception of ourselves in the medical community and how patients are seeing us. 63% of healthcare providers say that they see a decline in compassionate care over the past 5 years. We live in a country that spends the highest number of dollars on healthcare in the world. And yet, when we look at the healthcare outcomes, depending on which survey you look at, we're about 27th in the world. This is not okay. So, what are the causes? Why have we gotten where we are today? Many will say that applying the business model to healthcare has been part of what has made it so dysfunctional, because we're not about lean and mean and doing the most with the least possible. We need to do the most with enough so that we can fill ourselves up and deliver the care that we came to this profession to deliver. There's been an explosion of technologies which are both wonderful with the new capabilities we have. However, sometimes it means that we're so glued to technology that we forget that there's a patient attached to the illnesses that we are investigating. Extensive administrative burdens that have fallen to providers pull them away from connecting with patients and have them clicking boxes on computer screens. We've heard so much this conference about burnout, a lack of training for the emotional labor of medicine. There's poor role modeling because the generation of physicians and nurses that actually came to the profession with time to really take care of patients have become so burdened that we really look for islands of light in our profession where we can say that person exemplifies the care that I want to emulate. The master clinicians. We need master clinicians everywhere to inspire and to role model what our trainees are learning. We have moral distress about not being able to deliver care that we would like to. And we know that from the top of the White House down, the norms of civility have just changed in our country, and we need to pull them back. So what's at stake? Well, we know the patient experience definitely depends on how we show up and what's in our hearts when we show up with patients. Adherence to recommendations, health outcomes, the quality of care, the safety of care, provider engagement, clinician burnout, and more malpractice claims. All of this contributes to escalating healthcare costs. So our Surgeon General noticed and spoke about the fact that drugs don't work for patients who don't take them. And so we know that the relationship is really what gets people motivated to take the recommendations that we make. My team at Mass General did a 3-year systematic review and meta-analysis of all the randomized controlled trials that claimed that the patient-doctor relationship actually affected healthcare outcomes. And you might be surprised to learn that this meta-analysis showed that just relationship factors are significantly changing some of our most vexing healthcare problems, including obesity, diabetes, hypertension, asthma, lung infections, and unexplained medical illnesses. This is big news, and somehow we're not getting the message out that the outcomes that we're all working so hard for are really a function of how we connect with people and how we motivate them to take care of themselves. It stands to reason that there would be fewer malpractice claims if there's a strong relationship, because humans make errors and patients are human and they understand that we might make mistakes, but if we've been rude, short, clipped, and unattentive to our patients, they're not going to be as forgiving as if we really had cultivated a relationship. So the burnout issue is ubiquitous, and there are a lot of efforts being made to help doctors, nurses, individuals engage in greater self-care. I like this title, Don't Avoid Burned Out Physicians, Avoid Institutions That Create Burnout. So we have a systemic problem. We have some expanding roles now. We have chief wellness officers. We have people dedicated to making sure that the healthcare workforce is taking care of itself and engaged, but we have a lot of work to do in this space. Burnout leads to attrition, which leads to elevating healthcare costs, because replacing even one doctor or nurse is extremely costly in the hundreds of thousands of dollars. So my research is based on empathy, and empathy is needed for compassion. In order to be compassionate, we need to perceive the suffering of others or the joy of others. It's not only about tuning into suffering, it's tuning into great outcomes as well. So if we're talking about delivering compassion, I think of it like a sponge. You cannot wring out a dry sponge and get water. You have to fill the sponge. We fill the sponge with our perception, with our connection, with our attunement to others. And when that experience is full, typically it motivates a response of compassion. It's only when that sponge is so waterlogged and there's no one there to actually motivate the wringing out to get the water that we get in trouble and we get overburdened and waterlogged. So the perceptive abilities help us with cognitive empathy, where we take the perspective of others, where we understand what is their situation, what is their community. If I order this albuterol for the asthma, is there mold in the house where they're not really going to benefit from this medicine because there's a problem that is greater than the symptoms? And then affective empathy is that part of us that gets moved by really being affected by what's happening in other people. We have automatic mirror systems in our brains that help us connect on a neurobiological level, and that motivates what's called empathic concern. And that's where we either decide to respond with compassion, with sympathy, which is I feel bad for you, which is quite different from I feel with you. And also a response can be personal distress. Personal distress comes when we don't have community and engagement with others to talk about and to metabolize some of the strong feelings that we're exposed to in healthcare. So that's where the wellness programs are so needed and so necessary, because in order to show compassion, we have to have a reservoir that's filled. So I'm going to share a story that will illustrate to you how one patient that I interacted with actually led to a whole body of research and intervention research that came from learning how to really tune in. So this patient has given me permission to share the story. I use a different name at her request. So Jane was a patient who was referred to me by her nutritionist because she wanted to lose weight. The nutritionist had asked Jane to write a little story about her relationship with food. And Jane ended up writing a 20-page paper. And it was all about her relationship with her mother and how conflicted that relationship was, which led to having a really unhealthy relationship with food. Jane's nutritionist said, I really can't help you, with any kind of diet or anything until you sort out your relationship with your mother, and I suggest that you, sort this out with someone. So Jane came in, and she was the daughter of a single mother, who had a few children, and some of them had mental or physical disabilities. Jane was beautiful, very intelligent, extremely intuitive, and her mother looked to Jane for emotional support. In fact, she used Jane almost as a therapist and unburdened herself about all of her many difficulties and challenges. Jane was really close to her mother, but over the years she started to gain weight. And her mother needed one child to be perfect. And as Jane gained weight, the mother sort of turned and started ridiculing her and really being emotionally abusive. We worked on setting limits with her mother for a couple of years in therapy, and she did it. They formed a much healthier relationship, but Jane did not lose 1 pound. And she almost shut down the conversation if we ever sort of got anywhere near the reason that she came for therapy in the first place. So by serendipity, one of the residents that I was supervising came up with this idea. He knew I was interested in empathy, and he said, you know, there's a lot of biometrics on measuring patients' anxiety and what's going on with them physiologically, but I wonder if people feel listened to and empathized with, I wonder if their physiology actually matches up. So I want to do a study where we hook up patients and doctors and see what happens when they have an interaction, and maybe if patients feel listened to and understood, my hypothesis is that their physiology will line up, because that's the good feeling you get when you feel understood. So I thought this was fascinating. I thought it was a great idea. And he came back to me a few months after he got IRB approval, and he said, I'm having trouble recruiting people into this study because we want to videotape a psychotherapy session, and we want to do physiologic monitoring while doctors are with their patients. And nobody wants to do this. In psychiatry, we're not that used to having, you know, our sessions filmed. There's a lot of privacy issues, obviously. So he said, if you would be a subject, I think other people might say yes. So I really hadn't had my arm twisted to do this, but I thought of Jane and the fact that we'd made so much progress, but we were kind of stuck. And I asked her if she'd be willing to participate, and she said, sure, if this helps, people, I'm happy to do it. So we had our session recorded, and the next day, my resident called me up, and he said, you will not believe this. You have to come here and look at these tracings. So I went and looked at them, and I was truly shocked, because Jane is very poised. She's very self-assured. She comes across like she's at the top of her field, and she's actually intimidating. But when we saw the tracings, we saw that her anxiety, her physiologic activity was literally off the charts. We were in sync, but I was going like this while she was going like this. And her physical demeanor did not display this at all. So I went back to Jane and I said, we got some sort of interesting findings here. Are you interested in seeing them? And she said, yes. And I looked at it, I said, I was kind of surprised by this. And she said, I'm not surprised at all. I live with this every day, but no one has ever seen my pain. And she started to cry for the first time. It was like someone held up a mirror to what she had been hiding. And what we realized was, by keeping this good face up for her mother, she had learned to completely wall off her anxiety. Shortly after this, Jane decided that it was time to do something about her weight. And she hired a trainer. She started to work out once a week, then twice a week, then 3 times a week. And over the course of the next year, and I should point out, Jane had never lost 1 pound in her life. She had just gained. That next year, she lost 40 pounds. So, with this serendipitous research project, we revealed that we actually had tracings for emotional activation. So this led to an idea that I wonder if doctors could see the impact on their patients, like when they are short with them, or hurried, or rushed, or not giving them time to explain things clearly. I wonder if it would change to see that their words or their lack of words is really hurting the patients. So In this study, many doctors and patients ended up participating. And this is one example of like one of the lowest correlations of physiology. You can see that the patient and the doctor, they're just not on the same wavelength at all. And here's an example where they were extremely in tune. And this session actually got like perfect scores on empathy. So we could see that you actually can measure when people are in sync and when they're not. So you might say, what is so big about one person's physiology setting off a new way of looking at things? And has anyone in this room read this wonderful book by Frieda Fromm-Reichmann called "To Redeem One Person is to Redeem the World"? She was a psychoanalyst who worked with the sickest psychiatric patients whom everyone else just thought were a lost cause, and that, like, why bother spending time? Their minds are so disordered, and there's nothing we can do. Well, she didn't believe that. And she, with her superb ability to connect, instill hope, and believe that people could get better, showed that an honest human connection can actually heal a very disordered mind. You might be familiar with Paul Broca, who was a physiologist in the mid-19th century, who did an autopsy on the brain of a man who couldn't speak fluently. And by doing this, he identified Broca's area, which we now know is where the language centers are. So a single case can sometimes be enough to convince a whole medical community that we can locate things or measure things that no one thought we could measure. The work we did with Jane and that physiologic study was published in the American Journal of Psychotherapy. They were excited about this research because it could show that you don't always have to do massive studies, huge clinical trials, to make a point about how people connect. But sometimes writing up a single case or a single story. We had a session on storytelling and story writing yesterday about how important it is to share our stories, in all these circles to get people to think about the impact and the power of caring relationships. I just am going to show you all the areas of the brain that are involved in empathy. We have motor resonance that helps us feel when, like, someone cuts themselves or gets their hand caught in a car door. We have sensory resonance when we see someone cry and we feel ourselves welling up. We have the ability to mentalize, which is our ability to take the perspective of people that we've just met, and we know a few things, and we can picture, like, what must this be like for them? How are they facing that challenge based on having more information? And then the ability for self-other distinction, which means I know my pain and I know what your pain is, and even though I'm empathizing, I am not letting your whole experience overwhelm me. And in our empathy training, this is one of the most important learnings, which is how to calm yourself down, how to self-regulate, so you don't end up overwhelmed with the degree of pain and suffering that you might be facing every day at work. So I came up with a way to remember how we connect with people non-verbally, and I realized that the word empathy actually was the acronym that mostly worked, because E stands for eye contact. There's no F in empathy, but there's an M for muscles of facial expression, so noticing and accurately reading people's facial expressions is a way we really connect. P is for posture. A is for naming the affect or the emotion to ourselves when we're with someone. T is for tone of voice and the power of touch. H is for hearing the whole person. And Y is your response. And by your response, I mean, how are you responding physiologically? How do you feel with this person? It's not what comes out of your mouth, but it's, do you feel at ease? Do you feel you were helpful? Most feelings are mutual, and so if we're feeling good about an interaction, chances are so is your patient. But if we're not, it might be an invitation to try to repair a rupture. So the brain imaging studies on empathy and compassion are just fascinating. And I got to take a deep dive into this literature when I took a medical education fellowship at Harvard, where Dr. Beth Lown was one of our co-leaders. And I just want to say that Parker Palmer said, how you teach is what you teach. And the way Dr. Lown and Dr. Hayden, they are an amazing duo, the way they taught us as fellows was so filled with the compassion and loving kindness that she talks about. It really transformed all of us, to the point that when our fellowship was over, everyone was really sad. And we gave Dr. Lown an award called the Gentle Sage Award. And nothing fits her better than her wisdom being conveyed in such a gentle, kind, and loving way. And I'm so grateful to you for that. So, you know, in medicine, you have to write papers to get people to take notice. And I was fortunate that after this fellowship, I pulled together what I learned about the neurobiology of empathy and wrote this paper that was published in JAMA. And it kind of set the stage for a new conversation that empathy was not just a small, soft, nice thing to have, but it was actually hardwired, and we can either upregulate it or downregulate it. The question was, can you teach it? Most people, back when I was doing this, believed that you had a fixed amount of empathy and you either had it or you didn't. So we applied for funding to do a study to test the empathy training that I had developed based on neuroscience to see if it actually worked by improving patient ratings of physicians' empathy. We did a randomized control trial where a computer randomized physicians into a training group and a control group. We had patients rate the level of empathy on an empathy scale that I'll show you before the training period. And then 4 to 6 weeks after the training, we had them rate physicians again. A randomized controlled trial, as most of you know, is the gold standard for proving causality if you do an intervention. And also, we used patient ratings because self-report measures only tell you what that person thinks about themselves. But what we really need to know is, what do our patients think about us? So briefly, some components in our training had to do with educating doctors about how empathy works. How do you prepare? How do you perceive and listen and show curiosity? How do you shift perspectives? How do you respond to people's emotions and not just their behaviors? How do you address challenges to empathy? How do you self-regulate and deal with emotional dysregulation in yourself and with others? How do you incorporate mindful practices? And how do you expand empathy and compassion? So our outcome measures, I'm going to just show you 3. One was, did they improve in the knowledge of how empathy works? And you can see that, the trained physicians knew about twice as much as the untrained. We embedded facial expression decoding into our training because, first of all, we wanted our physicians to start looking at people's faces at all. And it was a bonus if they could distinguish the difference between anger, surprise, fear, disgust, and contempt. Because you really would respond differently if someone is disgusted versus if somebody is sad. So you can see that there was a lot of work to do on facial expression decoding. The improvement in ratings, of the percent of physicians that improved was twice as big as the control group. And then these were the items that we used on a measure called the CARE measure. I'm not going to read them all, but I think you all know that p-values at 0.05 or less are statistically significant, and we were thrilled to see that the ratings showed that they really felt more cared about, more listened to, and that things were explained clearly. Our one-year follow-up study showed that the learning was retained, and our program evaluations showed 90% or above found the material interesting, the training helpful, and the learnings able to implement in practice right away. And then the specific trainings about emotion recognition and regulation and relationship management all got 91% or above. So how do we create a culture of empathy? We can't just train one sliver of the medical team. We have to train everyone. And at this point in time, even veteran and people who've been in the profession a long time, they need brush-ups because a lot of bad habits have crept in, and there's a lot of unlearning that's happened by the de-skilling that's happened with the use of the computer. So we need to really reach all members of the team. Empathy improves clinician meaning in work, and it decreases burnout. The burnout statistics are really alarming, but I see it as a call to building resilience. Instead of fretting about the number of burned out physicians, let's get together and figure out how do we address what really matters to people. The Inspector General wrote a report about what is happening on the southern border, and he wrote about a little boy who said, "I can't feel my heart." This is a devastating statement, and I worry that a lot of healthcare providers are not feeling their hearts. And I think what we have done is get so task-oriented that we've closed off the humanity that has drawn us to these professions. We're caring and taking care and getting the joy of making a difference in someone's lives is one of the biggest privileges and one of the best jobs we can have. So I'm going to close with how do we close the compassion gap? One is we need leadership commitment. And that means working together to approach leadership, not one at a time, but with thoughtful plans, consideration for what can happen, and patience for implementing things that are realistic but doable with a goal of transforming healthcare. We need structural changes. There's been a lot of work done on duty hours. There's so much more to do. Mark Linzer did a study on burnout. He's at University of Minnesota. He found that just by removing the competing priorities of picking up children in daycare and finishing your shift for nurses was a strong antidote to burnout. But if you have to decide between your patient care and not picking up your child in time, that is an untenable decision. Structural changes like that, this study showed it went a long way in improving burnout. Providing training. How many people in this room are already providing some kind of training to improve empathy and compassion? So we all have our own calling for what we're here to do. There are so many types of training, from bringing the arts into medicine, from experiencing more time with patient stories, from learning how to write narratives, from empathy training, compassion training. Bundling some of these things together and not having like a one bullet that you think is going to do everything, but banding together to come up with programming that actually combines some of these wonderful things. And combining that with community building, something that Schwartz Rounds does so beautifully is to bring communities of doctors and nurses and staff together where they can process the emotional labor and the joys of taking care of patients. And finally, working together, including your colleagues, finding leaders, finding these islands of light that are already in your organizations, coming together to work together is how this is going to get done. And not forgetting that at the core of this is bringing the heart and the humanity back into healthcare. I want to just say that much of the work that I've described is in much more detail in my new book, The Empathy Effect. We're getting more copies today, so there should be more around noontime if you'd like to get a book. And I'd like to finish with this quote. Your vocation lies in that place where your deep gladness meets the world's deep need. Thank you for all the work that you're doing.